So in any case, my name is, if you don't know me, my name is Ramzi Arpachi Dussault. I'm in the computer sciences department. And today we have a Red Talk. Red Talks are hosted by CEDIS, our new School of Computer Data Information Sciences, and also a few departments, one within CEDIS, which is the Computer Sciences Department, and then our friendly neighbors over in the EC department representing ECE. It's a new professor, Umit, over there, whom you can see if you're looking at the picture. So, and he and I will be kind of running this, hosting this talk, along with Vaso Fanta, who works in CEDIS and kind of is amazing and does everything over there and has helped get this cool talk together. So thanks, Vaso. So it's our pleasure today to have Faisal Mushtaq with us. He's an alum. So fantastic to see alums who go off and spent some period of their life here with us so many years ago and then have gone off to great success. And one of the reasons we were particularly excited to hear from him was really the sense of, years ago in the world of computer science, you go into computer science to go into the computer industry. And that's still, of course, true. And many of the folks, if you're students in this computer science or computer engineering, you will do that. You'll go work at, Google or Microsoft or something like that. But increasingly, there's so many fields of the world that are being transformed by computing and data. And so we're really interested in learning more about one of those spaces today. That's healthcare, health tech. Excuse me. So we're really lucky to have Faisal here. He's been working in the space for many years. He's a senior VP right now, and he's going to talk about give some perspective on that from a person inside the field. So welcome, Faisal. We're sorry we can't have you in person. Hope to have you in person at some time when the world allows it. But please take over. And one more thing, one program note. If you have questions, please put them in the Q&A and we will see them and then interrupt Faisal to ask him the questions. So welcome.
All right. Well, thank you so much, Ramzi, for giving me the opportunity to share a bit of my experiences in the healthcare industry. Can you hear me okay? Is the sound okay?
It's good, yeah. Okay,
fantastic. So yes, thank you for the introduction. It's been a very long time since I graduated from college, and so it's always fun to come back and see how things are progressing. Today, what I wanted to share is that it's when I first graduated from college, it wasn't one of the things that I ever thought about. It wasn't one of the things that I was exposed to, and was not even a thing that I ever wanted to go into, primarily because I did not know what it was. And equally importantly, I thought there was nothing exciting going on. I'm not a physician by education, so what do I have to do with healthcare? So stayed away from healthcare for a long, long time, naturally gravitated towards telecommunication, worked in some very large telecom projects, ultimately one day made the transition to get into healthcare. So now that I'm in healthcare, I'd love to share one of my reasons, what are my reasons to work in healthcare, and what are my reasons to stay in healthcare. And more importantly, I think wanted to share my reasons for why I think all of you should seriously consider healthcare as a career growth area for all of you as professionals and as individuals and as brothers, sisters, parents, friends. This is just much more real to be doing something that touches healthcare. So with that, if we can transition to the first slide, what you see there is essentially something you've heard a lot. We read in the newspaper all the time. It really truly is fascinating to see how much of our money that we spend every year as a country goes into healthcare. So we hear that, we hear why, we are the biggest among all the developed countries. We are spending the most of our GDP on healthcare, as you can see on the chart from the right side. I mean, it's not even within a margin of error. We are overspending the biggest spender by a lot. So we really are having a good time with the money in the US on healthcare. And you'll find plenty of people who will tell you that, we are spending money that's not necessary. We're spending money on things that are not required. But when you talk to physicians, they'll tell you that their reimbursements continue to go down. When you talk to pharmaceutical companies, they'll tell you things are not good. So there is something there that doesn't meet the eye. So what I wanted to do today is to share with you what are some of the, I call it the underbelly of the beast, and how we as professionals, specifically as a computer science professionals or computer engineering professionals, and even business majors, lawyers, privacy attorneys, all of us can play a very important part in not only bending the curve, but kind of bring it more in line with what it needs to be. So as we look at the next slide, that's another perspective on the relative size of the economy versus. So it isn't that we are spending most money, we're actually spending more money per person. So there's something definitely broken. And if we go to the next slide, there's just one last perspective on money. You can see that we are spending enormous amount of money, almost $10,000, $11,000 per person, compared to even Japan or United Kingdom, which have really reasonably good healthcare. So we are not even in the margin of slightly above. We are just seriously above. So let's look at what I believe are some of the fundamental reasons and why this is an exciting area. So, U.S. healthcare is primarily organized but it's an organized chaos. Things are done for very good reason, but if you try to trace back, it was never designed from the start. It is kind of like, ultimately it's kind of spaghetti code. It's all over the place. It does the thing. It does it reasonably well. But is this the best way of doing it? No. So it is really big time spaghetti code right now. Everybody has their fingers in everything. It's very hard to trace anything. It's very hard to find defects. And most importantly, it's very hard to fix those defects. So just building on that analogy, there are two types of groups that are involved in providing healthcare to us as consumers. They are the care enablers, health systems, the hospitals, the clinics. They're the pharmacy benefit managers, people who manage how much you will pay for your pharmacy drug and which drug you can actually get. Sometimes even your doctor does not decide that. It's the brand benefit managers decide it. And then pharmaceutical companies that actually are doing the basic research of building these drugs and innovating new molecules, be it specialty medications or standard medication. So these are the folks that are involved in providing the care. And I can talk about other things such as pharmacies and all that. So these are the people who are actually on the receiving end of providing end of the care. And there are a whole bunch of people that are actually paying for it. And this is one of those weird things that the people who pay for care are actually not getting the care. So if you think about it, for most of us, our employers pay for our health care. And what are those places where you actually go to a restaurant and you say, I want to eat the most expensive stuff on the menu and send the bill to somebody else? I mean, yeah, when we were younger, we used to do that with our parents. But in today's environment, it doesn't work that way. That's not how market economics work. So employers are paying the bill. And many commercial health plans, such as United Healthcare, Cigna, Anthem, all these plans offer two kinds of things. One is either they are administrating a plan on behalf of an employer. So for example, if Walmart has insurance for employees, many health plans are actually just managing Walmart's plan. So they charge a fee. And they have necessarily no interest in trying to save money for Walmart because Walmart ultimately is picking up the tab. And then they also have their own plans where health plans take the risk of providing care. But what is most important and most fascinating thing is almost 50% of US healthcare is actually paid for by the government. Almost 50%, which is part of our Medicare program, Medicaid program, the Obamacare program. So without getting into the politics of single payer, socialism, all that stuff, because I'm not the most qualified person to comment on it, but I can tell you that a very large portion of US healthcare is already being managed by the US government. And then there are employers who are paying for it. So what you see here is that there's a lot of people, and I call it lots of hands in the cookie jar. And when you have a lot of hands in the cookie jar, it becomes very hard to manage who's eating what, whether they're taking their fair share. And in order to manage the cookie jar, then you have the camera systems installed everywhere. So if you go to the next slide, what you see is in order to manage this chaos, there are lots and lots of regulations, processes, guidelines that somebody or the other has put in place. So a health plan has an enormous amount of administrative processes that they put on everything. Government has enormous amount of administrative processes to manage Medicare and Medicaid spend. Then in order to protect the privacy of individuals, because this is healthcare, government has extensive privacy regulations. So now there are at least two people with a lot of money and a lot of time who are trying to regulate spend of money. Nobody's really even worried about the care quality right now. We're just worried about how to save money. So privacy, protection of privacy plus saving money is enormous bureaucracy built on top of it. And then comes the clinical part of it, which is, does Faisal, if he's pre-diabetic, what medication he should be getting? And do doctors agree on what medication he should be getting? Do we need one CT scan or two CT scans? Do we need an MRI or just a CT scan? All those guidelines that are designed, they are designed to provide appropriate diagnosis. So it comes down to a point where who can get care and who doesn't get care, whether you should get a CT scan or not, whether you should be getting medication or not. There are lots and lots of clinical guidelines. Once clinical guidelines are exercised, on top of it, you see a massive amount of administrative guidelines, privacy guidelines. And just to make these things even more complicated, and hopefully by now you're getting a feel for why we are spending trillions of dollars in managing healthcare, is not because healthcare is important, healthcare is expensive. It's the business of healthcare has a life of its own. So just to make this a little bit more fun, there are a whole set of other regulations that are around kickbacks and self-dealing. And these regulations are put on top of health systems. These regulations are put on top of doctors. So what does that mean? What that means is, if I'm a doctor, and this is not too far in the past, what used to happen many, many, many years ago is, if I were to go to a doctor and the doctor would prescribe me one medication, he or she would actually get a kickback from the pharmaceutical company for prescribing one medication versus the other. And so that, one could argue that the doctor was always trying to do the right thing for the patient, but one could also argue that a $10 drug is probably as good as a $100 drug. But if a doctor gets a kickback, he or she will always probably go for $100 medication. So the government again came in with this regulation saying, as part of the administrative process, there is going to be anti-kickback regulations and self-dealing regulations. For example, if you go to a doctor and the doctor said, Faisal, you must have a CT scan, but at the same time, his brother is running the CT scan shop. So sending you to one of the associated business, it's kind of a self-dealing. So just figuring out whether you need a CT scan, and on top of it, figuring out whether there is a self-dealing going on, there is then this additional layer of bureaucracy that comes into action. And everything that you do in healthcare becomes a nightmare of process, regulations, guidelines, contractual oversight. So it's just, so far, if I haven't freaked you out, you probably are not listening to what I'm saying. It's nuts. So let's go to the next slide. So when we think about innovation, which is one of very important things when I graduated from college, is I want to go out there, I want to create new things, I want to make the world a better place. And when I was working in telecommunication, and when I wanted to pursue a new thing, there were two things that I would always worry about. I would always worry about the technology risk of doing a new thing. Can I build it? Can it scale? For example, what do you think is what was the risk of sending a man to the moon? There wasn't a business risk. Nobody was worried about the price, the value creation, the market size. Everybody was focused on the technical risk because they had never sent a man to the moon. They didn't know how things will operate in low gravity, or when you have escape velocity, what will happen. So there was a lot of technology risk when people were trying to innovate and send a man to the moon. There was little business risk, if any. I mean, the U.S. government was underwriting. So if it took $2 billion or $20 billion, the money was always going to be available because the president of the country said so. But as we innovate in the business world, there are two things that get the most focus, which is technology risk and business risk. But when you walk into healthcare, the most important risk you have to worry about is the regulatory, ethical, and compliance risk. For example, let's take a very simple example of cloning. Do you think there's a technology risk? There was. Of course there was. It was a new thing. People were trying to do new things. Was there a business risk? Everybody agreed that if you can start cloning things, you can change DNA, you can make a lot of money. Not millions and billions, but probably trillions. However, the biggest consideration in innovating going down that path, and this is one of the reasons why compliance, cloning is still illegal in most, if not all countries, is an ethical and a regulatory risk. Because what you will build, is this the right thing for us as a society? Is that the right thing from a self-dealing perspective? Is there an anti-kickback issue? Is there a privacy issue? I mean, if I can go get the list of all UW-Madison students, and I can find out if I can get access to their medical record, and I can find out who has a specific disease, and then I can go sell that information to pharma company, there is technology risk is there, business risk is there, but even though I can make money and it can be done, it's not something I will do because there is a regulatory risk and a compliance risk. So as we think about innovation in healthcare, the conversation becomes a little broader and some of the priorities of things change. So in my experience, with the exception of several things, as you think about innovating in healthcare, unless you are doing a vaccine for COVID, or you're finding a cure for Alzheimer's, usually there is enormous technology risk in doing those things. But other than some of those big, audacious innovations, the main risk in healthcare is regulatory compliance and ethical. So as we go to the next slide, what you see is, in order to manage this complexity, bureaucracy, business process, technical risk, it really truly takes a village to innovate, to do anything meaningful. It takes business people, it takes lawyers, be they are privacy attorneys, patent attorneys, contract attorneys, physicians, of course. Nothing will get used if the physician don't trust your innovation. Scientists, it requires scientists because they need to be the people working on discovering new drugs. Economists, because if you can't prove that something generates value, either dollar value or societal value, it's not going to go anywhere. And then, of course, computer scientists, people who are savvy on computers, with computers, know the science, know how to do things to minimize the technology risk to the extent possible. So it truly takes a village to do anything small or big in healthcare. And that's one of the reasons why I feel a lot of technology savvy people really don't get excited about healthcare because there are lots of issues when you're dealing with stuff like this. And I put myself in a shoes where I say, well, how much of this is overboard? I believe a lot of the stuff is overboard. We really don't need to do this. But some of it is important because when I think about it as a consumer, and I think about it as a father or as a brother or as a son, I do believe that many of these things are important. Privacy is important. Ethics is important. Confidence and trust is important. So some of these things are very important and crucial, but we can always get rid of the whole bunch of bureaucracy nonsense that we have built into the system. So it offers an enormous career opportunity for all of these people to get involved in healthcare because all of these people are essential to improve and bend the curve that I showed initially, which is healthcare needs to become a smaller part of our GDP rather than a bigger part of GDP. Because if we stay in this course, the only thing we as a country can afford is healthcare. Everything else we won't have any money to work on anything. Forget about transportation, forget about supply chains. We'll all be working either in healthcare, providing care, or getting care, which is not sign of a healthy economy. So let's go to the next slide. And let's do the other way. Sorry. Whoops. Okay. So I wanted to pick one of these things up at a time and just give you my perspective on what this group can do when you get into the real world, in commercial organizations. There's a lot is being done right now to remove administrative burden by using AI-first approaches. So what does that mean? So for example, you go back, and I'll use some of the really simple examples. There are very complicated examples as well, but let's start very simply. 5 years ago, when you would call your health plan and you're trying to get your benefits, they would actually have a human answering the phone, and they will tell you what your benefits are, how you have used your benefits, and then you would say, hey, if I were to go to this doctor, what would be my copay? If I were to go to this doctor, what would be my copay? A lot of that was done on a phone call. So every phone call on an average costs about $70 or more. So that's a cost, and that $70 is money that's not being used to provide care. That's an administrative overhead. So there are many companies now that are coming in and building these AI bots and things that can provide you very comprehensive views and answer very intelligently your questions about your health benefits, about your copay, without ever talking to a human being. So there is, on an average, somebody estimated that for every dollar spent in healthcare, at least 25 cents is used on providing administrative overhead, at least 25. So think about if we can solve this problem, our healthcare cost will go down by 25%, which would be, guess what, $250 billion or more, maybe I'm not, 16% of our GDP is a lot of money. So 25% of it is probably trillions of dollars. So there's a big role that computer science folks can play in starting to automate and change things in the administrative side. And this is one of the biggest area of investment. So when I look at health plans, United Healthcare, Anthem, et cetera, if I were in the market looking for a career opportunity, I would try to understand what are these folks doing around AI, because those folks are spending the most amount of money in the administrative side of things. And I know groups that have been formed, just like in JP Morgan and stuff. There are groups that are formed in all the major healthcare companies where they are leveraging, they've built AI shops, and they're recruiting hundreds of people to work on just different projects to reduce the administrative processes down and automate as much of as they can. So that's one area for folks with computer science expertise who can come in and truly change the tide. If you go to the next slide, the next area that I can think about is, I don't know how many of you think about healthcare and real-time transactional networks. I mean, before I moved into healthcare, I used to work on telecommunication networks. So networks, for example, one of the network I was building was the FAA network that kind of used for tracking airplanes in the air. And it had triple redundancy, less than 60 millisecond fault tolerance. And that was all very exciting things. And, and I had a lot of fun when I was doing it. Now, when I come to healthcare, believe it or not, healthcare also has huge number of real-time transactional networks. These transactional networks that require very sophisticated engineering and computer science are high availability, extremely scalable, and very reliable. So why do we need all these things in healthcare? So let's think about it. Let me use a real-time example. So I go to a physician and I say, I have flu. And the physician says, okay, you should take this medication. I'm sending your script to the pharmacy. Guess what just happened? From their system to the pharmacy, she just sent a real-time transaction that was made on a high availability network, which connects all the physicians in the country to all the pharmacies in the country. So what you saw is a small example of a real-time network. Now, building that network, running that network, you can't do that unless you know what you're doing. And as the complexity of the networks are growing, we are recruiting more and more very highly qualified computer science, computer engineering folks who actually know how to deal with these problems. So prescription is one. When you do the same thing with labs is another thing. Every time that a prescription is written, and this may be, I don't want you to feel like this is normal. I'm not suggesting it's normal. I think it's a really bad thing. But every time a prescription is written, a transaction, there are 11 transactions are generated from that single interaction. Now, if you were to ask me, do you really need 11 transactions? The answer is no. But because healthcare is so distributed and disjointed, that a transaction travels from the doctor's office to the pharmacy. Another transaction travels from the doctor's office to the health plan. Another transaction travels from a health plan to a benefit manager. Another transaction travels from a benefit manager to a health plan. So there are at least 11 different transactions that are happening in real time without your knowledge. But when you get to the prescription to pick up your medication, that's when they know what prescriptions you asked for, how much is your copay, how much is your employer going to pay for it, how much is the total price of the drug, and also how you should take that drug, and what interactions that drug can have. all of these things are happening in real time by the time a drug leaves a prescriber's office and ends up in the pharmacy. So as I think about these transactional networks, and my business at Change Healthcare, I'm actually building and managing two of the largest healthcare networks in the country right now. One is a real-time clinical data transactional platform, which means if I show up at an emergency room, the doctor in the emergency room will have the ability to, in real time, pull my data from all over the country to see, do I have any allergies, or do I have any pre-existing conditions? Today, what happens is if I show up at an emergency room, the doctor, if I have a penicillin allergy, and if I am not able to talk at the emergency room for whatever reason, I had a car accident or whatever, the doctor has no way to check. So what they do is they give you small doses of things to figure out. Now, with building a real-time nationwide clinical data interoperability network, you can real-time pull that information without ever asking the patient, who's your doctor? Because this network does not need to know who your doctor is. So that's another area of healthcare where I think, what you guys do is very, very crucial for us to continue to build what we are doing. If you go to the next slide, this is yet another example. This may be a little bit more scientific, and some of you, this may be even a better, it gets you more excited is, we all know how, as an example, we all know how radiology works. So radiology, you go to X-ray, they take an X-ray, and they ask you to wait because somebody's reading your X-ray, and then somebody reads your X-ray 2 hours later, or maybe 3 days later, and then they tell you, you have no broken bones. And then you say, okay, you go home happy. Or they come back and say, well, you have a broken bone, or you have this issue in your hand or leg or whatever. So think about all the human processes that has gone into reading an X-ray. So there's a lot of work going on right now where X-ray is probably the first one that we have already on the path of solving, make it completely humans free, is using machine learning, image processing. Machines can read X-rays and figure out what the issues are, and in real time they can tell you that whether somebody has an issue. What is even more interesting is that on an MRI or on a CT scan, people are building diagnostic tools now, mostly scientists and physicians partnering with computer scientists to figure out, if you look at an MRI, what can you find a cancer? So think about, we have to train those machines to understand what to look for. And over a period of time, they get pretty good. So just think about how much pain and suffering can be avoided if you are no longer counting on one person to look at something and over a period of time. Just think about the cost saving and the benefit to the patient care and the speed of patient care. So this is one very fairly new and very exciting area where people are now using machine learning, AI techniques to build out these diagnostic tools for all kinds of diseases. And I think that is worthwhile for many of you to think about. So if you go to I think this may be the last example. So just, there's a lot, like I said earlier, there is a lot of things you can do. All of you are highly qualified, very sought after professionals. None of you will have any issue finding a job. And I think it's actually getting better for you, getting worse for the industry, but getting better for you. But think about, you can get a phone call from somebody who's trying to build another ad. It's my favorite example and my pet peeve. Somebody can call you and say, hey, I'm building a new ad algorithm so that we will further target the advertisement so people can buy more of my thing. Hey, I'm building a new version of Yelp, so you can crowdsource this and social media that. All very worthwhile professions. I don't want to take anything away from them. But think about if you were to consider taking your skills and your passion, what is that one place, at least in my mind, that actually is not only offers a great challenging set of problems, but also provides, in my opinion, one of the strongest personal satisfaction reward. I mean, I've been in situations where I sit down with people and they say, my mother has this disease and she was in a lot of pain. And I've had it more than one occasions, was able to say, that drug you're talking about? I was part of the technology team that created the platform to speed up the drug discovery process. And their eyes light up. Just think about the human dimension and the meaningful difference you can make to individuals, not just people you don't know, but maybe people in your family, people in your friend's family. So this for me is very personal. This for me is very real, and this for me is very rewarding. So as I think about careers, I think about healthcare. And one of the things that I always tell people is healthcare has so many problems, not just me, but my kids and their kids, and probably their kids will be busy for a long, long time because we have made a mess out of it. So I can go for, there is always a desire to go create the next Amazon or go make the next big thing. What I've learned in healthcare is there's no shortage of doing small things. There is so much low-hanging fruit. It's mind-boggling, the amount of money we are wasting and the simple solutions that can be offered in healthcare. So there is always going to be a group of people who get inspired, appropriately funded, to go boil the ocean, change the trajectory of the country. But for most of us, there is enormous opportunity for us to focus on low-hanging fruit, very challenging stuff, but still stuff that we can do in our lifetime without having to go legislate or change things or have everybody and their brother agree with us. It's just that real right now. So with that, if I go to the next one, that kind of basically sums up my pitch of why I went into healthcare, why I feel healthcare is such a compelling career for very, very smart people, and why I think it is a area that needs strong technical brains to be focused on.
Hey, Faisal. Thank you. Thank you very much. And we would do a loud applause right now, but it's a COVID era, so you have to pretend people are applauding for you. My apologies for that. Great talk. Thank you so much. So if it's okay, we'll do some Q&A. We're already getting some questions popping up. I guess I'll start with Professor Shima Banerjee, just more of a compliment. He said, very well articulated advocacy of why CS folks should go into health tech, make excellent points, and thank you for this talk for us and our students. Another question is, and then he has a question, a follow-up question. My question is, yes, there are low-hanging fruit, but the labor of understanding and forming a team that spans the different dimensions appears challenging. How do CS folks cut across different disciplines that you outlined, legal, physicians, economics, et cetera?
Yeah, so I mean, this is truly one of those places where I have seen, let's talk about entrepreneurship. So if the question is coming from a perspective of entrepreneurship, then an ideal team that I've always seen become very successful is a healthcare practitioner working with a technical person. So that I would consider that to be the bare minimum, especially if you're going after clinical innovations. if you're purely going after administrative innovations, sometimes you can get away with not having a physician. On the other hand, if you are building a diagnostic tool, then a physician is absolutely the bare minimum. They can always go partner with technology people, but without knowing what to look for in a X-ray or a CT scan, it's really hard for them to innovate. So I have seen that a group of 2 people minimum with the right skill set is a good starting point. When it comes to lawyers and others, there are so many folks that are available that can be deployed or leveraged on a contract basis or a time and material basis, but you don't necessarily need them on the team because, initially, but you need to find the right people because, you have to ask the right question to get the answer you need. So if you form a poorly formed question, the lawyer may not be able to give you the right response, and you may start off on a wrong thread. So always talk to more than one lawyer, not because one lawyer doesn't know what he or she is talking about, but you could always ask a different question and you can get a different answer. But at a minimum, the biggest challenge for entrepreneurs is to find 2 like-minded people. When you work in a smaller company or a bigger company, then some of those core competencies are already available. So there I don't see that as a major issue because I work with very, very competent people and they have a lot of experience in either law, the business, regulations, everything. So it's easier to get absorbed. And there are folks who will tell you how to do something. Because if you go work in a bigger company, they know what are the legal boundaries to do something. So initially, you don't have to go figure everything out on your own. You don't have to be on your own. But if you want to start a company right out of college, then you would need at least 2 core people, 1 technologist and 1 who's somebody very familiar with clinical knowledge, domain knowledge.
Thank you.
There's another question. So you mentioned that a database that can be accessed by doctors nationwide. So is this type of a database under development right now? If so, by who? If not, who is going to initiate this project? So companies may not invest.
Yeah, so this isn't quote unquote a database, it's a network, right? So we connect thousands of sites to each other. So as part of that, the goal isn't to go collect the data and do something with it, because that's where the law comes in. You need the data rights to do anything with the data. So the starting point is, which I call the phone network, right? You have to put down the phone network in the ground so you can get a dial tone. Once you get the dial tone, then you and I can decide that our conversation is going to be broadcasted or it will be private channel encrypted so only you and I can understand. But rather than all of us trying to lay cables between your house and my house, the first thing that the industry is working on is laying the groundwork for a multi-point network. And that will then build on, that would then allow us, so I call it the internet phase of healthcare, where we are putting the internet in the ground. At this point in time, the people who are laying the internet did not know that one day there will be a company called Amazon or there'll be a company called Facebook. So we are at that level of construction phase in healthcare where we are building this massive networks, in my company at least, nationwide networks. So what happens next is, maybe this generation that I'm speaking to, maybe the generation after that, is going to come up with things that we'll all be sitting and saying, wow, never thought about this one. So we are in that formative stage. But we are not building a national database of data because that won't even be legal.
So thanks. There's another question, which is, so what do you think about the remote health monitoring with wearable devices? What are the challenges in that area? Do you think it can have a huge market share in the healthcare industry in the near future?
Yeah, so there are 2 ways to think about it, and I'm clearly not an expert in remote monitoring. So one is the device itself, right? So there is a lot of time and money being invested in building devices that actually can capture data. So for example, you think about Apple Watch. Now that's a remote sensing device, which is collecting your data. And so what Apple is doing now is they've figured out, based on enough data, they've figured out what is the data saying. So first is Apple Watch. The second one is when you collect the data, what kind of knowledge do you gain from that data? What kind of lens you have on top of that data? And therefore, what predictions, if any, you want to make. So there are two separate disciplines, and there is a lot of money being spent on both. Just remote monitored data is not enough many times to come to an actual outcome. Because it's one of those things. Me telling you you should eat healthy doesn't mean anything unless I know, number one, you're not eating healthy, and number two, me knowing that you like fried food. So one is making a statement which is not actionable. The other one is actionable statement. So actionable statement comes with analytics that is built on domain knowledge. So if somebody has these heart rhythms a certain way over the last 40 days, and then they had a heart attack, that's one set of knowledge. You extrapolate it over 100,000 people or 1 million people. Now you have very high level of certainty that these were false alarms, but these actually led to a heart attack. So there's a lot of work being done, but one on the remote sensing side, and the other one is, now that I have the data, does it tell me anything? Does it tell me something meaningful? And what action can I initiate from that meaningful data?
Thank you. There is an interesting question. How do you deal with the reluctance of clinicians to accept the build fast, break fast philosophy of CS?
I'm sorry, you're breaking up. Can you repeat the question?
So how do you deal with the reluctance of clinicians to accept the build fast and break fast philosophy of CS?
So how do I look at the
Build fast.
I think
physicians?
it's referring to like I don't want to call that a philosophy of CS. I want to call that a philosophy of like Facebook, which is build fast, break. It's like basically go fast and break things. But to me, like, I don't want to be associated with that as a philosophy of CS. But basically, is there maybe a general way of looking at it? Is there a culture clash between some ways CS people look at development versus the reliability that you need to really build healthcare systems?
Okay, I understand.
Yeah.
So I think, this is one of those challenges in healthcare as well. And it's a good one. It's a real challenge. So there is no shortage of people. And I think this is I am not a physician. I don't have a medical degree. So I've gone through the same set of challenges. Just because I think I can solve a problem means nothing. It means nothing to a physician. It means nothing to a practicing doctor, because there is no shortage of opinions of how they should be doing their job, and there is no shortage of things people want them to do. So let's take a step back and think about physicians. So, God bless them, they do very, very important work. My daughter is a physician. So on an average, a physician sees 30 patients a day, 30. Because they have to pay bills. Because of this administrative burden, every dollar that they collect, 40 cents, 40, is given to nurses and administrators and billing people and front desk. So for every dollar that they make, 40 cents goes away. And then 60 cents is what remains. And then they have to pay taxes and all that stuff. So the net is, in order to be a profitable business, because ultimately most of the physicians are running a business, they have to see anywhere from 30 to 38 patients a day. Now, we go to them as technologists and we say, hey, you should take a minute and go to this app and do something. And we get this blank stares. What? 8 hours a day, 8 multiplied by 38, blah, blah, blah. When do you want me to go to this app? And is this app going to make me more money? Or is this app going to allow me to see more patients? And when the answer is, it will make your life easier, they check out. So thing we have to understand, and that was a big realization for me early in my career, was I look at physicians as small business owners. They are in the business of care, and they are very caring people, but ultimately they have to pay bills. So when I bring forward innovations to them, there are two fundamental things I have to think about. Is it going to increase their revenue? Or is it going to increase the velocity of their business? And those are the fundamental things that drive. And so with that said, as you think about innovation, we as technologists are used to trying things and think about if we are doing something like that, we want a physician to try something. And what if that person, that physician, wants to try it on your mother? Would you be okay with that? Probably not. So as these people are thinking about providing care, they're thinking about, do I have a strong enough confidence that what I'm trying to do now, I can do it with my own mother? And if they don't feel comfortable and there is not enough data to support it, they're not going to do it, even if you give them $1 million, truth be told. I mean, there is always people who will do it. But so that's why there's a disconnect between in the technology industry, our feeling of, rapid innovation, agility, let's fail fast. It doesn't work that way in all places in healthcare. Some places it does. Most of the places it doesn't, because you're talking about human life on the other side. So as long as we can understand, and that's a frustrating part of healthcare for a technologist, but as long as we understand it takes longer, it's more painful, but the reward, both financial and personal, are disproportionate, I'm all in. But you have to appreciate that going in.
Thanks. Amit, you have one that you want to ask?
I think there is this question from a student. Can you talk about the career opportunities in this domain?
So career opportunities?
In this domain, yeah, job opportunities in this domain.
So, I think there are, I think I was trying to mention earlier, is that, there are people who are being hired as architects for building networks. There are people who are working as on the AI teams, building new models, be it neural network models, machine learning, on the business process automation side, on the clinical diagnostic side. So there are a whole host of opportunities. I mean, people who are in hardcore computer science, they want to write compilers or operating systems. We have these medical devices that require embedded system knowledge that is extremely complicated, and they are fault tolerant to a point where you cannot, for example, think about it. You have a heart device in your heart, and this thing has a bug, really? So it's stuck, it gets stuck, so you have to do Control, Alt, Delete. It doesn't work that way. So every shade of computer science and computer engineering person can find a very, very rewarding career in healthcare. So for example, same thing, somebody who's in a power supply design or battery design, these devices that are implantable are becoming smaller and smaller. They need power sources. They need power management. So there are so many things that happen in healthcare, and healthcare is such a big beast that you can do the right thing. You can do a lot by working in healthcare. So, So, Medtronic, Boston Scientific, Pfizer, like I said, United Healthcare, hospitals like University of Wisconsin Health System, all of these places have enormous opportunities for computer science people. The only places where I think you may not have a lot of hardcore computer science need is probably in a hospital itself, because they're usually doing, not always, but they're usually doing mostly business applications. For some people, that's a good career for them. But if somebody, like for example, I started my career by doing, I was doing embedded systems. So that was the most exciting thing I could do. And if you are in that side, you can always go to a device company or a MRI system company, and they're always looking for smart people. I think the challenge is that not enough people with our pedigree show up. And so, but there is those opportunities in my mind are there.
Thank you. So I think we're running short on time. Maybe we'll just do one more question and then wrap it up. Unfortunately, more questions than we have time. So thank you, everybody, for the great questions and engagement. I guess maybe the last one I'll ask, from what I saw in my 27 years at Epic, now retired, working on the financial side, the real solution to administrative burden is political, not computer driven. Do you think there's any chance that this can really happen, that we can solve some of these problems?
So I think I mentioned that. So yeah, so I appreciate one of my, I think one of my fellow healthcare IT person is on the call as well. So appreciate you joining. For me, there is always the politics of healthcare, and then there is the business of healthcare. So I definitely have very strong point of view about what we can do and how we can fix healthcare. But I'm also focused on what who's not a senator, not a representative, votes maybe once every 4 years. What can I do? How can I add value? For me to add value is by improving and automating many business processes that were designed back in the paper ages, or sometimes make sense, most of the time don't make any sense. And how do I do that without deploying more humans? And I think AI, machine learning, these things, and I know these are overused terms, but I honestly believe that AI, machine learning, these things can really help cut down that cost, because all of us are getting older. Think about if 10% of the population, and I don't know the exact number, let's say 10% of the population, US population is 65 years and older. And we all know that more than 80% of the cost of healthcare for a person is spent in the last 10 years of their life. So just think about it. If over my lifetime, if I was going to spend $100 on healthcare, $80 of those 100 will be spent in my last 10 years. So as the U.S. healthcare as the U.S. population is getting older, we'll have more and more people that will be in the extremely high cost area. So we have to find a way to reduce cost by as much automation as we can. And as long as we have, a Senate and a Congress that's, doing what they don't do or not doing anything material, it is down to us technologist people to continue to find ways to improve things. So I am optimistic that we will get better in our political world, but I'm also being pragmatic personally and trying to push how can we speed things up and take out cost from the system.
Yeah, thank you. So thank you again. Again, we would clap for you at this point one more time. So thanks so much for the fantastic talk, and I'm sorry that we didn't get to all the questions. I think it just shows that we have room for some further conversation with you when you have the chance. Lots of interest in this space and really fabulous talk. So thank you again for coming. Thank you, Lasso, for your work in spearheading the Red Talks. Thank you, Amit, our friend from BSEE, coming over and co-hosting this with us. And thank you, everybody, for attending. I guess this
Well,
is
thank you very much for everybody's time, and I